Okay. Our next speaker is Dr. Yochai Birnbaum from United States. Dr. Yochai Birnbaum has completed his MD in 1982 at Hebrew University, Jerusalem, Israel. He's a professor of medicine at Baylor College of Medicine in Houston, Texas. He has published 386 papers in reputed journals and has been serving as an editorial board member of several journals. He is editor-in-chief in cardiovascular drugs and therapy. The title of his talk today is Diagnostic STEMI in Patients with RBBB.
Okay, good morning.
Good morning to you too, Dr. Birnbaum.
Yeah, okay, let's see. Do you see the screen, my screen?
Yes, we can see your screen.
Okay. So this is a simple talk and clinical one. So we'll start. We were told for years that right bundle branch lobe is not as bad as left bundle branch lobe. We were told that left bundle branch lobe is always associated with structural heart disease, whether cardiomyopathy, coronary artery disease, and so forth, associated with bad prognosis. But right bundle branch lobe is not. And actually, we can identify ST segment changes, and therefore, right bundle branch lobe is not contraindication for regular stress test. However, in the last few years, things started to change. And I think Widimsky et al., a paper in 2012, started it. He reported on 6,742 patients with acute myocardial infarction who underwent coronary angiography. Not necessarily STEMI, but all acute myocardial infarction. 427 patients, 6.3%, had right bundle branch lobe. 53% of them with ST segment elevation. When they had CAS, TIMI flow 0 in the infarct-related artery was found in half of the patient with right bundle branch lobe versus only 39% of patients with left bundle branch lobe, 57% of the patient with classical STEMI, and 22% of patients with ST depression. TIMI flow 0 in the infarct-related artery was found significantly more in patients with new or presumably new right bundle branch lobe than in the group with known old right bundle branch lobe. 3 vessel disease were found in 35% of the patients with right bundle branch lobe, 30% of patients with STEMI, and 53% in patients with ST depression, myocardial infarction. And in-hospital mortality was 14% in right bundle branch lobe, 13% in left bundle branch lobe, only 5.4% in patients with classical STEMI, and 6.3% in patients with MI with ST depression. So again, in-hospital mortality was higher among patients with new or presumably new right bundle branch lobe than in patients with pre-existing right bundle branch lobe. 19% versus 6%. Another paper from 2016 by Chen evaluated 11,830 patients with acute coronary syndrome. 5% had right bundle branch lobe on presentation. Right bundle branch lobe on presentation, and they don't say new, presumably new, or old, but right bundle branch lobe was associated with older age, male sex, more pre-existing risk factor, higher Grace risk score, worse Killip class, and not surprisingly, was significantly independent predictor of in-hospital mortality. Odds ratio 1.45. but not 6 months mortality. It didn't reach statistically significant. Angiography revealed that LAD disease, left main disease, and 3-vessel disease were more common in patients with right bundle branch lock than without right bundle branch lock. So the association of right bundle branch lock with mortality was equally seen in patients with ST segment elevation myocardial infarction and non-ST segment elevation ACS. Another paper that was just published in the American Journal of Cardiology, they retrospectively analyzed the outcome of patients with anterior MI with and without right bundle branch lock. So among 1 million patients with anterior wall STEMI, 1.8 had right bundle branch lock. Again, right bundle branch lock patients were older, had significant comorbidities than patients without right bundle branch lock, and the mortality was higher, 15.3% versus 9%. So right bundle block was associated with increased 30-day mortality, higher rate of heart failure, complete heart block, and the need for permanent pacemaker. They could not separate old and pre-existing right bundle branch block from new because they use ICD codes and not actual interpretation of data. Based on the first two studies, the 2017 European Society of Cardiology guideline for the management of patients with acute myocardial infarction with ST segment elevation concluded or recommend patients with myocardial infarction and right bundle branch lock have poor prognosis. It may be difficult to detect transmural ischemia in patients with chest pain and right bundle branch lock. Therefore, a primary PCI strategy should be considered when persistent ischemic symptoms occur in the presence of right bundle branch lock, which is actually a major change of policy or recommendation compared to the previous guidelines or the American Heart guidelines that didn't mention anything about right bundle branch lock. Let's discuss the right bundle branch lock. So the right bundle receives its blood supply from the anterior septal branch of the LAD alone or with the AV nodal arteries that come from the right or the left circumflex. So dual blood supply. A proximal LAD occlusion can result in new right bundle branch lock, which is often accompanied by left anterior fascicular block because the right bundle and the left anterior fascicle receive the same blood supply. This type of intraventricular block are mostly reversible with nowadays reperfusion therapy, PCI or thrombolytic therapy. This is a case of a patient with right bundle branch lock, left anterior hemiblock. There is ST segment elevation in one AVL V1 to V4 with reciprocal ST depression in the inferior wall compatible with STEMI due to proximal LAD occlusion. Transient right bundle branch lock in inferior STEMI is rare. Theoretically, it can be explained by ischemia of the proximal His bundle, selectively inhibiting the conduction system like a patient with pre-existing critical stenosis of the LAD. The His bundle is dually supplied by the AV nodal branch and the first septal branch of the LAD. However, the right bundle branch lock can be unknown before because we don't have previous ECG, rate dependent, etc. So not necessarily every new right bundle branch lock or presumably right bundle branch lock is ischemia of the proximal conduction system due to LAD disease. This is an example of a patient with right bundle branch lobe and has ST segment elevation in the inferior leads, ST depression in 1 and AVL. So we don't know. It's old, pregnant, unknown before, or new. Right bundle branch block and left anterior fascicular block have also been demonstrated in patients with acute total left main occlusion. So differentiating acute total left main occlusion versus proximal LAD can be difficult, but with proximal LAD, there is usually ST elevation in V1. And it is said that because left main occlusion causes concomitant ischemia of the circumflex, which may cause by itself ST depression in V1, the sum of the vectors is either electric ST in V1. But Fiol from Palma de Mallorca demonstrated right bundle branch lock in more than half of the patients with acute total left main occlusion. This is a patient with right bundle branch lock, left posterior hemiblock, ST segment elevation in 1 AVL, V2 to V6. So it is probably proximal LAD occlusion, but with left posterior hemiblock. We have no explanation how ischemia can cause it. And one thing I can say, you should differentiate it from right axis deviation due to Q or QS wave in 1 and AVL. This is, I call it left posterior because there is an initial R wave and then S wave, which is maybe semantic. So based on this data and our observation, we published in Journal of Electrocardiology this year, is right bundle branch lock the new left bundle branch lock? Are we going to repeat the same mistakes? And by meaning it, that there was a mistake that left bundle branch lock is a sign of acute ischemia and should be part of the STEMI guidelines. New or presumably left bundle branch lock was considered an indication for primary PCI. And more recently, we found out that actually most cases with new left bundle branch lock or presumably new left bundle branch lock are not acute ischemia due to occlusion of an epicardial arteries, and they are not indication by itself for primary PCI, but simply you can't diagnose ischemia using the ECG in patient with left bundle branch lock, and therefore you should be, if the symptoms continue, if the patient is hemodynamically unstable, taking for the cath lab, but may not be with the STEMI time frame. So complete right bundle branch lock is commonly found in the general healthy population, about 1.4% in men, 0.5% in women. Possible cause including trauma, infiltrative disease, degenerative disease of the conduction system, structural changes, inflammation like old myocarditis, and myocardial infarction. A large percentage of individuals with right bundle branch lock have no clinical evidence of structural heart disease or coronary artery disease in the general population. Over the years, conflicting data have emerged concerning the long-term prognostic significance of right bundle branch lock in individuals without overt cardiac disease. Overall, it seems that after adjusting for age and other risk factors, isolated right bundle branch lock is not an independent predictor of adverse outcome in stable patients. Some studies suggested when combined with left anterior, left posterior fascicular block, right bundle branch lock predicts mortality. So what are the possible explanations for the poor outcome seen in patients with right bundle branch lock? So patients with right bundle branch lock may have more LAD disease pre-existing, either as an infarct-related artery, anterior STEMI, or concomitant stenosis. Patients with right bundle branch lock have more diffuse pre-existing coronary artery disease. Patients with right bundle branch lock have larger infarct, leading to pressure or volume overload, stretching the right ventricle, and therefore somehow causing transient right bundle branch lock. Right bundle branch lock is a surrogate marker for older age concomitant, maybe non-ischemic risk factors that affect prognosis, and a certain form of STEMI, anterior infralateral, are missed in patients with right bundle branch lock, and I'll go to show you a bit. So as I said at the beginning, it is commonly believed that right bundle branch lock does not interfere with the diagnosis of STEMI. Therefore, the official diagnosis of STEMI in right bundle branch lock are the same as for people with narrow QRS. However, infralateral, what was called before posterior STEMI equivalent, the ST depression in V1 to V4 or V3 is challenging because patients with right bundle branch lock tend to have ST depression and T-wave inversion in this lead. And prospective studies are needed to define if we have a threshold for ST deviation in this setting. So this is an example of patient with a little bit of ST segment elevation in the inferior leads, ST depression in 1 and AVL, and he had ST depression and T-wave inversion in the precordial lead. So is this part of his posterior or infralateral involvement? It is clear because he doesn't have right bundle branch lock. But when we see it in a patient with incomplete right bundle branch lock, and you see here the ST depression and only T-wave inversion in the inferior leads, is it part of incomplete right bundle branch lock? Is it part of infralateral infarction? So now you have a patient with right bundle branch lock and ST depression here with biphasic T-wave. T-wave inversion in the inferior lead. Now what you see? Would you call it acute infralateral STEMI and activate the cath lab if he has typical symptoms? Say, oh no, this is just secondary to the right bundle branch lock. We simply don't have any guidelines what to do. You see, this patient has minor ST segment elevation in the inferior lead. He has kind of incomplete right bundle branch lock, and he has ST segment depression here. So if you can activate the cath lab for the minor ST segment elevation in the inferior lead, but may not for here. Now, the same patient, this is his previous ECG, few days before. So you see he had the same amount of ST segment elevation in the inferior lead, maybe with negative T-wave, but he did not have the ST segment depression and the T-wave inversion in V1, V2. Is it enough to reliably diagnose STEMI? My experience, not. My experience that if you look on ECG of patient with right bundle branch lock, incomplete or complete, you will see fluctuations in the ST and T wave in V1, V3 that I cannot explain. Not everything is STEMI, but in the right context, you should be suspicious. So then we go, if right bundle branch lock is usually causing ST depression V1 to V3, if we see a patient with chest pain, right bundle branch lock without ST depression in the anterior lead, or with minor ST segment elevation. If the baseline with right bundle branch lock should be ST depression, should we use lower threshold to diagnose anterior STEMI in patient with right bundle branch lock? There is no data, there are no guidelines, and this might be an explanation that we misclassify or do not diagnose anterior STEMI and infralateral or posterior STEMI in patients with right bundle branch lock, and therefore some of them have increased complication simply because they don't get the deserved reperfusion. Another example of right bundle branch lock with no, maybe a little bit of ST segment elevation in the anterior lead. Be suspicious. And what about incomplete right bundle branch lock? This is a patient with incomplete right bundle branch lock, left anterior hemiblock, ST segment elevation in inferior lead, and ST depression here. Again, we don't have criteria for complete right bundle branch lock. We don't have criteria for incomplete, and we don't know if we should use the same threshold. This is a patient, right bundle, left posterior hemiblock, a little bit of ST segment elevation here with T-wave inversion, ST depression here, and the inferior lead. Should we activate the cath lab? The threshold of the ST is not enough by the guidelines if he is a male. So conclusion, the association of right bundle branch lock, at least pre-existing, and acute myocardial infarction is most likely representative of more severe coronary artery disease pattern and or more extensive comorbidities and age. On the other hand, development of new onset right bundle branch lock in a patient with STEMI, especially anterior STEMI, could have different implications suggesting imminent risk. The reported finding of lower survival, particularly in the early post-infarction phase, is an observation that merits further scrutiny. Currently, there are no sufficient data to support activation of primary PCI protocol for patients presenting with symptoms and right bundle branch lock without ST segment elevation, as the European guidelines have changed based on the Widimsky paper. Presence of TIMI-0 flow by itself is not a proof that reperfusion therapy will alter outcome. It can be old pre-existing occlusion. So we need more data, more research about it, and it's very difficult. However, if symptoms persist despite initial medical therapy, urgent coronary angiography is warranted, as the guidelines say for all patients with ongoing symptoms or hemodynamic instability despite not meeting ECG criteria of STEMI. Those are the current guidelines. Thank you. Are there any questions? You can't hear you. You are muted.
Thank you so much, Dr. Birnbaum. If anyone has any questions, please ask them. And of course, Dr. Birnbaum email address is mentioned in our chat box.
Okay.
I think Dr. Ramchandran, you are on mute. There is a button at the bottom of your screen. Please click on that and you are on mute so you can speak. Okay, again, Dr. Ramchandran, you are on mute. Let's see, he's trying to talk. but he's on mute. I think he can't hear me. Okay, Dr. Birnbaum, thank you so much for your
You're
talk.
welcome. Thank you. Goodbye.